And I'd like to introduce today Dr. Jonathan Neufeld. He has been with the Telehealth Resource Center here for many years, since it was conceived back in 2010, and has recently moved and taken a new position as Vice President of Information Technology and Integrated Care at Oaklawn Psychiatric Center. So, Jonathan, go ahead and take it away.
Thank you, Becky. All right, we're going to talk about integrated primary care today. I am excited to be able to talk about this. This is one of the major projects that we've been working on here at Oaklawn for the past few months. Although I have to say that there are a couple of things about my job, my position here, that I'm still adjusting to. One is the fact that it's actually two jobs, that I have integrated care and information technology. So there's a lot of information technology stuff that I've been doing for the last few months, and the integrated care doesn't always get to bubble up to the top. But the other is that it used to be that I had a lot more time to make slides. So today we're going to be seeing some slides. This is just a pretty rough outline of what we're doing. I'm going to avoid apologizing in advance for the slides. I'm hoping to communicate the ideas across well, but we're gonna get into this and talk about the content rather than how impressive my slide skills are. How's that? So let's go ahead and get started. I am, as Becky said, I'm the VP of Information Technology and Integrated Care at Oaklawn Psychiatric Center. Oaklawn does about 16,000 visits a year, 850 employees, 4 major locations in 2 counties in north central Indiana, Elkhart County and St. Joe County. We have been up here for almost 100 years. You know, I better not say how long. It hasn't been 100 years. It's been 50 years, about 50 years in this area, although it's only been 2 years since we expanded out of Elkhart County into St. Joe County, just about doubled in size. I am a clinical psychologist by training, have been the clinical director of the UMTRC for a number of years, as Becky said, and I've been in the field of telehealth for about almost 15 years. I'd like to be able to say 15 years, but can't quite yet. And I just talked a little about Oaklawn. We have 4 major locations. It includes an inpatient hospital of 16 beds, and that's the state limit that you can have. It's not that we're trying to be small, it's that, or any of us inpatient facilities are trying to be small, but we're limited by law to 16. We do outpatient services of all ages and have several locations in both counties for access there. We also have a child and adolescent residential facility in Mishawaka, suburb of, or right next to South Bend there, as well as several assisted living or group homes across the 2 counties. And we do a number of other projects with school districts and the state and other organizations, as does any community mental health center, I'm sure, in the state. We've been doing integrated primary care for a number of years, and our current integrated primary care program involves 4 clinicians, a PhD and 3 LCSWs at 5 different clinics across our region. HealthLink has a clinic in Mishawaka. Indiana Health Centers has actually 3 different sites where our clinicians are located, where we have 2 different clinicians located. One, a fairly large health center in Mishawaka, and then a small program focusing primarily on homeless and at risk of homeless folks, and then another small clinic on the west side of South Bend that's fairly new, Bendix Physicians. And then Heart City Health Center in Elkhart is another contractor of ours that we work with to provide integrated primary care there with an LCSW. So these programs have been going on for a while. They're fairly successful. Our clinicians stay pretty busy at these sites, and we are able to draw them back into a team and provide those clinicians with a mental health home, if you will, and I supervise that team. And so that they can feel like they have a place where they can talk about their work, or they can get support, clinical supervision, develop better ways of doing things, and that's how we are organizing that program. Now, what I'm going to talk about today is not that program, but a new problem, a new challenge that we are addressing, and that is a desire to expand. Somewhat. Desire is maybe not quite the right word, but we've been in conversation with the local healthcare, provider, the largest healthcare provider. Well, I can't say that anymore. Goshen Hospital and Goshen Health System, which is an affiliate of Indiana University Health, has been here in Goshen for many, many years, and have affiliated with Indiana University Health in the last 5 to 10, somewhere in that range. And they own 10 primary care clinics in Elkhart County. So you've got an vertically integrated health system where 10 clinics spread throughout the county, and one hospital, and a number of other specialty centers and various facilities around. And they have a high need for mental health care in their primary care centers, and have really had a challenge getting that need met. And IU Health Goshen is a very high-performing healthcare organization. They really see the lack of mental health access as a big problem, and they have put a lot of effort into addressing that problem. And in the course of that effort, a proposal was floated where we could collaborate between Oaklawn, the major mental health facility in the area, and IU Health Goshen, to see if we could get better access in primary care clinics owned by IU Health Goshen. So we've been developing that project. Some of the problems that a project like that addresses, however, are interesting and maybe not unfamiliar to people in the webinar. But there, of course, is a high need for mental health clinicians in primary care. That's true across the country, and a low availability of those clinicians. But even when care is available, in that there's a clinic somewhere and a patient gets a referral to that clinic, the completion rates for those referrals are very, very low. Most studies put it under 10% somewhere, and I've seen 5%. I've seen some estimates a little higher. It depends how you measure it and how you operationalize that. But basically, when a doctor says to a patient, I think you could be helped with some mental health care of some kind, there's a facility or there's somebody down the road, I'd like you to go see them. 1 time in 10, that connection is actually made and results in some sort of care being delivered on an outpatient basis in the mental health domain. So we're trying to fix that problem, and there's a number of ways that we're addressing that. Also, the problem is exacerbated somewhat because of the variations in mental health and the approach to mental health that different primary care clinics take. Some are very active in trying to diagnose and find mental health problems. They want to keep those patients and try and treat them using whatever skills the physicians on site have, whatever resources they can bring on site. Sometimes those physicians are aware of the problem, they diagnose it, they advise patients and refer, just like I was talking about. Of course, very few of those referrals result in care, actually. And then there are some clinics that just say, hey, yeah, we have a big mental health problem, we know about it, but there's really nothing we can do about it. So, whether to actively engage, whether to just kind of stand by, or whether to just ignore and hope it goes away. I mean, there's a whole range of approaches, and I doubt there are any clinics, very many clinics anymore, who are saying, yeah, we're just going to ignore it and hope it goes away. But it is a challenge to try and figure out some way of effectively addressing mental health issues. So the problem doesn't stop there, though, because even for those few patients who do follow through and pursue mental health treatment, big barriers still exist. And Oaklawn found that as a community mental health center, CMHC, working with, we're a fairly large organization, working with the local hospital, part of the one of the early solutions was, why don't we just streamline and smooth out our referral process so we can take those patients that come more effectively. And the challenge for an organization like a CMHC, like Oaklawn, is that even when the patients get to the front door, there are still huge barriers. There's a mountain of regulatory paperwork that has to be completed for each open case, and we have to be careful to open cases in a certain way, to close them in a certain way. It leads to long wait times. It's still hard to access care, and we're fairly inefficient as a practice organization, simply because, like any hospital, we have to have a lot of people and run a lot of programs and cover the full gamut, and so we're not finely tuned to provide the kinds of services that a patient coming from a mental health organization would need. We're not finely tuned for the kinds of services that we could provide to a primary care referred population, and that's a bummer. So we got a big problem. That's what that ship is supposed to show. It's a big problem that's somebody's going to have to fix and see if we can address it somehow. There are a number of models, and I wanted to spend some time talking about models, but frankly, what my sense, academics have talked about models for a long time, and I have been involved in that discussion, and there is a range, and I'm not giving nearly enough time to that topic. One could go into it in depth. However, what I have found and what we have found in delivering integrated primary care is that it really boils down to how you deliver care on site, because there are lots of ways of engaging at a distance, and the fundamental problems exist when there's any distance between mental health clinicians and primary care. You have to bring primary care on. You have to bring mental health on site, and so the various models that talk about collaboration at a distance and other types of things. I mean, they're good, and when that's the best you can do, that's the best you can do, and you have to maximize the resources that you have. But we started from a position of, we're going to bring mental health, we're going to embed mental health in primary care. Like our current programs, we wanted to find a way to embed mental health in the primary care settings that IU Health Goshen had. And so that brings us pretty directly to a model that most people refer to as the Cherokee model. Cherokee Health Systems in Tennessee is an FQHC that pioneered this work, and they've been doing it for a long time. They have a training institute now in their organization where they train other organizations to do the kinds of things that they've done, which is embed mental health clinicians in primary care. And the core factors of the Cherokee model, if you will, and there's a financial model and that gets talked about, and how you do mental health in an FQHC setting. And I'm not going to address that so much as I'm addressing factors on the ground. What it boils down to is that the provider is on site, that the provider implements brief sessions and brief episodes. They work for half-hour sessions or shorter, just introductions and just very, very short interactions when that's necessary, when that's appropriate. But scheduled sessions, when they're scheduled follow-ups, they're half-hour sessions, and they're brief episodes. So 2, 4, 6, 10 sessions, not designed to manage patients long-term, not designed to manage complex outpatient mental health needs. Definitely designed to do rapid and brief interventions, but then refer out when more extensive treatment is necessary. Also, this model is characterized by an openness. In contrast to most traditional mental health care, it's characterized by an openness to interruptions and introductions. Interruptions that that means, when you're working with a patient, instead of having an uninterrupted 45 or 50 minutes, you've got a half an hour, and somebody might knock on the door during that half hour, and you answer and say, hey, can you meet a patient? So you tell your current patient, hey, give me just a minute, I got to step outside. You step outside, you meet the patient, say, hey, can you come back tomorrow? Can you come back Thursday? Or I'll be done in 20 minutes, can you wait? And so you're constantly managing an ongoing flow of brief interactions over the course of the day. And once you get into treatment with a patient, once you're working with a patient, you're having a very focused, intensive, but focused interaction, intensive and focused interaction on specific problems, taking a kind of a problem-solving approach. We're not trying to reorganize and overhaul your personality or make huge, life changes. We're trying to help you manage a current situation to get back to a functional level, help you access greater resources if you need them, help you make sense of your current situation so that you can sort of get the perspective that you need to move on, or develop a skill that's going to help you manage your health care or your mental health care going forward. They tend to be brief, focused interventions that are designed to get the job done, a job done quickly, not the whole job, but a job done quickly. And then the patient is released back into primary care. Treatment in the mental health part, the behavioral health portion of treatment is over, with the full expectation that, it might be 6 months, 6 weeks, it might be 2 weeks later, the patient comes back and says, oh my goodness, had another problem. Can we, engage again and let's work some more. And the model that's closest, or the term that I've heard that's closest to this sort of a model, is called brief therapy across the lifespan. We're really looking at brief interventions, but expecting there to be multiple engagements across the lifespan of a patient. And the key factor in making this work that we've found in working in primary care is this idea of a warm handoff. Warm handoff meaning that instead of just pointing you down the hall and saying, hey, go find the clinician, I think they can help you, somebody walks you down there and introduces you to the clinician and says, okay, this is Dr. Neufeld, he works here in our clinic, I think he's going to be really helpful to you. So why don't you work with him for a little bit and let me know how that goes. And that sort of a handoff is what makes the referral work. Instead of 10% referrals, we're getting 90% completion. There are very few, 95, 99 maybe, very few people who in that situation of a warm handoff will say, you know what, I'm just not interested, or this isn't going to work, or they'll meet the clinician, and then a number of people will just say, okay, I don't want to work with you anymore, I don't want to come back. And sometimes, it's going to cost extra money, extra copay, something, and that is a barrier still at that point. But at least we're getting that foot in the door, we're making a connection, we're letting the patient know, hey, there is a service here that can be of help to you, and they get a much better idea of what that service is and what they can benefit from, and so we get a much higher completion rate. So then, as Oaklawn, so now this presentation is really pretty blatantly show and tell. I mean, I'm telling you about a program that we're working on. There's a little bit of background of a national and a research kind of perspective, but I'm really focusing in on what we've done and how we've solved this problem. This information I'm providing just so that you can take the information and do what you will with it. We are in the early stages of implementation. Actually, May is our implementation month. So our clinician is on site as of last week, and we're starting to take referrals. And I'm coming back in August to let you know how the first few months went. So a little teaser for what's coming down the road. But today I'm just going to talk to you about the design of the program and how it's designed to work, how we came up with this design as we worked with Goshen physicians and their primary care group. So the exacerbating factors that came up as we were thinking how we're going to implement the Cherokee model is that we needed to cover multiple clinics. There are 10 clinics across the county, but we didn't have enough BHCs to cover them all. And even if we did, there weren't enough clients at all of those clinics because some are larger than others. Some are pretty small, single clinician or a couple clinicians, a couple of doctors, or a doctor, nurse practitioner, 2 docs and a nurse practitioner. So they varied in sizes. And so at some places there weren't enough clients to keep the behavioral health clinician, BHCs, behavioral health clinician. That's the people that I supervise, the LCSWs and PhDs in primary care. So there wasn't enough business to keep them busy at each site. So putting one person at each site was not very efficient. And then some of the sites didn't even have enough room every day of the week to house somebody. They had room some days when some of the doctors took their day off, but then other days they're full, and so there's just no place for a clinician to work. So we had this kind of many sites, many clinicians spreading out the resources kind of a problem. And so the challenge really came down to, can we find a way to use technology, leverage the technology skills that we have to cover these multiple clinics and still be faithful to the Cherokee model of being on site, taking referrals, taking warm handoffs, being available anytime the doctor recognizes a mental health need in the course of their day, without having to make them think about, how do I go about getting this patient into mental health care? Something as easy as walking the patient down the hall, or asking the medical assistant or the nurse to walk the patient down the hall to introduce them to the clinician. So that's what we're doing here. And our solution breaks down into several main principles that we were going to hold to. The first is that we're going to provide integrated care on site, and we're going to be available at all times on site. That's the best practice that we're implementing. Second is that we wanted those behavioral health clinicians supervised by a mental health care team so that they have a home, just like our current FQHC embedded physicians, or clinicians rather. They have a home within a group of mental health clinicians that are working in primary care. We talk about cases, we share ideas, and that's necessary to sustain that work. Otherwise, you've got a single clinician who's kind of on their own in a primary care setting, doing their own thing, and any of us in clinical work know that's tough and risky, just because there are going to be cases you don't know what to do, and you want a colleague to run ideas past and get ideas from. So we wanted to provide that kind of support for the provider, as well as the best experience for the patient. And then third, because of the limitations of Oaklawn providing the services, even if we provided the services remotely via telehealth, if it's an Oaklawn patient, then all of the regulations around being a CMHC obtain in that case. We have to open the chart a certain way, we have to document certain ways, we have to do intakes certain ways. We have to do all these things in order to fulfill our obligations as a community mental health center. And so in order to avoid that, we wanted the services to be technically provided by and billed out of the primary care office, because they have a different set of rules. They're not, they don't have JCO looking at their practices. They don't, I mean, obviously they have standards of care, but they don't have the same regulatory burden that we have as a community mental health center, or that a hospital would have. So, so that was a key factor that we had to implement somehow. It also allowed for the clinicians to make all their notes in the EMR, in the on-site EMR. It provided the best integration experience for the patient as well as the doctor, and of course avoided the overhead, as I said. So that was another key factor. We had to figure out a way to have the primary care clinic be the official renderer, the official provider and biller of all these services. And then the fourth kind of piece that made it possible was the technology that we adopted. And this wasn't a big decision or a hard decision that we made, but I think it was pretty critical in a number of ways. We didn't want a big, heavy, expensive solution. Frankly, we didn't have the money or the staff to support a complicated system. We needed something that was simple, that was mobile, and that was inexpensive. And so we developed a cart, and you see here in this picture, it's pretty bare bones. It's basically a beefed up IV pole with that one's got a 32-inch TV. The one that we use in the clinics are usually 26, 27, 28 inches, in that range, a little smaller than what you're seeing there, but a webcam. It's got a little computer hanging on the back that runs the software. And that one there doesn't have an external battery, but the one in the clinic does. So you can just unplug it from the wall and roll it down to the next room and use it for up to an hour without having it plugged in, or move it to the next room, plug it in again, use it. And it'll stay connected over Wi-Fi the whole time. So it's pretty easy to move around, pretty easy to to just kind of manhandle and drag down the hall. Just like you walk with it just like you would an IV pole. You can grab it by the scruff of the neck, kind of behind the TV, there's a handle, and just kind of roll it next to you down the hall, open your own doors, and it's very easy to move around. The other thing you'll notice about it, if you look closely, and if you've seen a few of these systems, it's designed for seating level height, not standing height. most telemedicine carts are designed around a standing person to stand there and type while they're looking at the screen. And that doesn't work in our situation because we don't want a patient looking up at a screen. We want them looking eye to eye into that screen at the patient, and the patient looking eye to eye back at the clinician. And so we designed our cart to work with patients who are seated. And I mean, so there is a trade-off there. When you first walk in the room with a patient to introduce the clinician on the screen, the camera is just picking up the strike zone only, from the shoulders to the knees until you get the client seated in a chair across from the clinician, and then you can make the introduction. And the medical assistant kneels down so that they're on screen, or squats down so that they're on screen and they can talk while they're in the room. Excuse me. So, but it works well. It works well as it's structured for that type of encounter that we want to mimic. We want to mimic the physical encounter of a patient being brought in and introduced to a clinician and sitting across a table from that clinician. So that's what we're trying to do with this equipment, and the equipment is really working quite nicely in that regard. The other thing we had to do was some logistics to work out how we were going to cover these clinics. Although we're starting at one clinic, we have to be ready to cover these clinics, cover multiple clinics. So what we're doing is we're mimicking the situation where the clinician would be rotating from clinic to clinic. So they're on site some days and then off site relative to that clinic some days, which with one clinic just means they're either there or they're back at their office at Oaklawn. But once we have 2 clinics or more, then that clinician will be on site and rotating from site to site on different days. And so they'll be either on site or off site relative to each individual clinic, depending on what day it is. But they have to stay available for handoffs at all time, whether they're on site or they're remote. And I'll talk about that in just a second. And then they schedule follow-ups when it's convenient for the patient. The patient is going to keep coming into the same primary care site to see the behavioral health clinician. And the clinician has a schedule at that site, and they can schedule the patient at whatever time it's convenient. And if the clinician's on site, they can see the patient on site. If the clinician is off site, they can see the patient by video. Either way, the patient is in the same room where the clinician works out of at the clinic. So some more details for the logistics. When they're on site, they function the same way I talked about as when I talked about the Cherokee Clinic. The nurse or the doctor can knock on the door and can interrupt the clinician, bring them out into the hall, introduce a new patient. The clinician will say, "Hi, yeah, I'm Dr. Neufeld." And doctor or the nurse will introduce the patient, and doctor says, "Can you wait 10 minutes? I'll talk to you in a little bit." Or, "Hey, I've got an appointment this afternoon. Can you come back?" Or, "I've got an appointment tomorrow. Can I schedule you for Thursday?" And in that way, make that connection without interrupting whatever they're doing. So it's just a 5 or 10 minute introduction that they're doing in that interruption space there. And then the clinician, once they're done there, then the clinician goes back into the room, finishes up the session that they're engaged in right now. When the clinician is remote, though, we wanted to mimic the same process. So the video system in the clinician's room is running constantly, or at least available constantly. And the clinician, if you've used Zoom, we're using Zoom just like today, although we're not using the webinar version of Zoom, we're using the direct version, the basic version, really. In that version, what you can do is you can basically make request a call. You can page somebody else who's on the system, and so our behavioral health clinician, wherever they are, whether they're at Oaklawn in their office or they're at a different clinic or wherever, they have a system on, their system is on, and they can be paged, or the local site can ring into their room and basically request a call. So they don't just bop into the room where the clinician is already working with the patient, but the phone rings, the video system rings. And the way we've worked it out is that it rings, and then if the clinician doesn't pick it up right away, the nurse on the other side knows to, okay, stop the call, wait a minute, and call again. In that minute, if the clinician can, wrap things up or say, excuse me, I got to step out to take this call or whatever, they do whatever they need because they know they need to do to clear their space, to get to a space where they can talk, because they know a call is going to come in a minute and they're going to need to introduce themselves and make that warm handoff. So that's how that works. Now, if they're free and they can pick up the call right there and take the handoff, they do it. If they're with somebody, then they let the phone call end, make whatever arrangements they need to, step out into the hall or wrap up with the patient, and then when it rings the second time, rings back after a minute, then they answer the call then. If for some reason the connection isn't made that way, they also have a cell phone that they can be paged, or we can make messages, send each other messages in the EMR. But that's our warm handoff system, so far it's working okay, and we're getting used to it. There are several main reasons that we've done it that way, and the primary one is that we wanted a uniform referral process for the doctors. And this is proven to be very interesting because, on the one hand, it's a design requirement. We want the doctor to not have to know, not have to care whether the BHC is on site today or not. Okay? We wanted the same process regardless of what day of the week it is. If the doctor sees a patient that has a mental health need, they tell their medical assistant or their nurse, and they say, I would like this patient to see the behavioral health clinician, or they walk them down there themselves, whatever. But we want the doctor to do the same thing regardless. Doesn't matter what day of the week it is, whether the clinician's on site or not. Uniform referral process. That to us was a key to success. The interesting thing that we found and that we're working through is that it is really counterintuitive for both the nurses and the doctors, because if you think about it, it's always been about whether Dr. So-and-so is on site. I mean, the only way you can get somebody, the only way you can make an introduction are the days that they're in clinic. Are they there? Are they around? Is Joe around today? I want to refer this patient. And then you pull them aside and you talk to them and you make the handoff, or you do a curbside consult, or is Phil on site? So because I want to refer a mental health patient, and then you make that handoff. We're teaching them, training them to not care whether we're on site or not, whether they have to access video or whether we're there. The process is the same for them. And that, we think, is one of our keys to success. So we're in this planning and implementation process, kind of up to our waist or so, and we realize that the billing folks at Goshen Hospital, Goshen Physician Network, they've got some problems, they got some questions, and so they come back to us and they say, the material you gave us on reimbursement is all great, but at Oaklawn or at FQHCs, the payer situation is much simpler, fairly simple, although nobody here at Oaklawn would say working with payers is simple. Excuse me. But still, we have one primary payer, and that's Medicaid, because we're a safety net provider. We have some edge cases, some fringe cases. And same with FQHCs. Medicaid, Medicare are their primary payers, and they have a similar system for both. But for IU Hospital and IU Health Goshen Physicians, they have a mix of payers, all kinds of commercial plans, as well as Medicare, Medicare Advantage, Medicaid, managed Medicaid. They have a wide range of payers. And that means that the rules covering telehealth are different. It wouldn't matter so much, except that each of these sets of payers has their own set of rules. In Indiana, fortunately, we have a telehealth parity law, like a number of states do, and so coverage for telehealth services is mandated for commercial payers. So the law doesn't say anything more than that. It just says you got to pay for it. If you pay for it in person, you got to pay for it over video. And so we're pretty much good to go with a commercial payer. That's good. It's been a while. I remember a time, and not so long ago, when the commercial payers were the toughest ones. Now they're, in a sense, the easiest ones, and certainly in this project, they've been the easiest ones from a regulatory perspective. Medicare, however, which is the oldest payer of telehealth in the country, but Medicare has some pretty strict guidelines, and one of those is that the patient has to be at a rural site. Well, poor Engelmeyer Clinic, where we're IU Health Goshen Physicians Rural Clinic, it's also called Engelmeyer Clinic for what it used to be called. It's in Napanee, a little town outside of Goshen. Poor Dr. Engelmeyer, when he built his clinic, built it on the wrong side of the road, because 100 yards away on the other side of the road is a rural area, and believe me, it looks rural. You can tell. There's nothing out there. But on his side of the road, it's not. So they don't qualify as being in a rural metropolitan statistical area, according to Medicare. So we don't qualify as an originating site under Medicare. And then Medicaid, if it were Oaklawn or if it were an FQHC, we've got a little, we've got an exception in the Indiana law that allows us to be any distance from the patient. But for IU Health Goshen Physicians, a commercial, a nonprofit, but a regular hospital outpatient clinic, they're not an FQHC, they're not a community mental health center, they're not a critical access hospital. They still have the 20-mile rule here in Indiana still applies to them. So the clinician has to be 20 miles away from the patient in order for Medicaid to pay. Well, poor Engelmeyer Clinic is about 18 miles from Oaklawn. So, so we're kind of stuck there too, although from Oaklawn's perspective, we've got other places we can send our clinicians. That's one of the things that we argued when this whole 20-mile rule was up for debate, is that it's really kind of arbitrary where the clinician is sitting. If it has to be 20 miles away from the patient, well, we'll just send them to another facility and we'll see the patient from there. And so that's in the works, and we'll see if our plans outlive the 20-mile rule, because it seems like that is about due to go away any time now. But at any rate, it made it very tricky for us to have to figure out every single time, who's the payer, can we see the patient by video or not? So what we ended up doing, we modified our solution slightly so that the clinician never bills for a handoff or for an introduction. Okay, those are 5 or 10 minutes at the most, probably 5 minutes at the most. It's not meant to be much of an interaction. We can do a little bit of, compassionate engaging and, connecting with the patient, but it's really not a billable encounter, never was. So we don't bill those. So whether those are by video or in person doesn't matter. But when the BHC, when the clinician goes to schedule a follow-up session, they're careful to schedule Medicare and Medicaid on days that they plan to be on site at that clinic. So for now, until we develop other workarounds, we're seeing Medicare and Medicaid in person, and then scheduling commercial patients at any point during the week, because we can see those patients by video whenever it's convenient. And like I say, we're working that around to the point where we can be more flexible with all the different kinds of patients. And the vision down the road is to have multiple providers rotating among multiple clinics. So we'll have a whole team of providers rotating among multiple clinics, handoffs taken by any available provider at any time, and follow-ups at any convenient time for patients at any site. This just sounds so wonderful. Fingers crossed, and sleeves rolled up, actually, is what it's going to take to get this done, not just wishing for it. We're gonna have to work hard at developing processes. But wait, you might say, if you're covering multiple clinics, remind me again, why don't you just put somebody at each clinic? Well, remember, we don't have enough people to cover every clinic. There's not enough business at every clinic to justify one person there. And if you have one person going between two clinics, then some days of the week they're not available, right? And we're back to the doctor thinking, now is the person on site today? We don't want to do that. We also have the ability with this model to ramp up when we add a new clinician. If we add another clinician, we can just move them into the rotation, and it's not all or nothing. They don't start at a new site with 0 referrals and have to build it up. They start in a pool where we already have a pool of referrals and a pool of patients, and they can work their way up and much more rapidly meet the needs at multiple clinics. Same way with adding another clinic. We can bring another clinic online and have access right away. Not a lot, but we can, ramp up our clinicians and our clinics sort of at the same time, but smooth over the jerks and discontinuities that might otherwise develop. And then at some point, we're going to be adding other resources as well, because we are intending to bring psychiatric resources to this partnership. And we're certainly not going to put a psychiatrist at each site. We want the ability to move that psychiatrist around as needed. And so we're going to need to have this telehealth capability as well as the flexible scheduling capability developed across our sites. And we want the doctors to be able to get people into the psychiatrist the same way they do to the mental health clinician. Not worry about what day of the week it is or when is the doctor coming. Just walk down the hall, make an introduction, say, I really think this person could benefit from psychiatric care, and let the clinician take care of it from there. That's how we want it to be for the doctors. So our current program is one clinician supervised by me at one clinic. That's IU Health in Napanee, Engelmeyer Clinic. You can see it on the map there. It's, like I say, 18 miles southwest of Goshen, about 15 miles. Oaklawn is on the north side of Goshen. There are 5 physicians there, possibly 6. I can't remember exactly how many. They just added another a nurse practitioner as well. So it's a pretty big clinic, and we expect to be pretty busy there. But also we have expansion plans. Depending, if we can make this work well, we have plans to expand to 9 other clinics across the network, and you can see those on the map. And hopefully, meet all their needs with the same model, just expand it out. The other interesting thing, the other sort of innovation that we're bringing to this is that in our other embedded FQHCs, we rent clinicians on an hourly basis. And in this model, in this agreement, we are rather contracting for monthly coverage. We're going to cover you and bill you a monthly charge to cover the clinic. Now, that means that we have a motivation to make sure we're obligated to make sure that someone's available at all times, which is going to push us into this network model with multiple clinicians available, because we need to be able to do that. But it also allows us to customize that team, to bring people onto that team, parts of psychiatrists like I was talking about, or maybe other specialists that we want to bring on, somebody who's an expert in trauma or an expert in children, working with children, someone who's an expert with families, whatever. We can access other skill sets as necessary. In addition, the primary care practice is motivated to fill the slots because they're paying a monthly rate. Now they're not, it's not each hour that needs to be filled necessarily, but they are still motivated to say, we're paying for this service. Let's get patients into it. We're not expecting that they need a whole lot of motivation because we think there's a pretty high need out there. We know there's a high need out there, but that arrangement does align the project a little more. We think it's a little truer alignment, so that we can, all groups involved can be motivated to work toward the success of the program. Our goals, and you've read ahead, hopefully, to see these, modest success is that we break even, but provide integrated mental health access. I mean, and Oaklawn, I think at the levels that we're projecting, Oaklawn's going to break even on this service. It's not a huge money maker for us. Same way with IU Health Goshen physicians. If those clinicians bill, the revenue that they bill accrues to the health system. I mean, we're turning over billing to them, to the health system, and they're billing the service and getting paid for it. So they're paying Oaklawn on a monthly retainer, so to speak. And then whatever work the clinicians do is being billed to the health system, and they're collecting that. And as long as those clinicians stay fairly busy, the health system will meet its expenses to Oaklawn, and they'll break even. But even if they break even, there still is the added benefit that their patients now have very good access to mental health care. Now, full success would be if they're actually doing anything better than break even. If they do, they're billing a little more than what they're paying. And the same with Oaklawn. If the system, the whole network of clinics pays a little better than it costs to field the team, then we're doing well. Of course, one of the places where this all started, and what would be seen, I think, as fabulous success by everyone involved, is because Goshen Hospital has Goshen Health System has risk-based contracts, is an ACO, has a number of ways in which they are paid for performance and paid for cost reductions. If we can actually lower costs for their Medicare ACO population or their Anthem at-risk population, that would be a huge, huge win for them, because that's part of the idea that's driving integrated mental health into primary care settings, because we know that at least there is research evidence to show that we can reduce costs in across all kinds of morbidity, all kinds of healthcare needs by using targeted mental health services. Not just mental health needs, but even healthcare needs, and healthcare expenses overall can be reduced by active and engaged and available mental health clinicians working with your population. So that's where we're trying to go. We're gonna walk before we run, but that's the idea that we could get to eventually, and really hope to see that. Goshen Health System is engaging with Purdue on exploring those questions and figuring out how to analyze that more accurately, so that they will know for sure, have a good solid set of numbers about how much this program pays back and how well it's working for their managed care, for their ACO and at-risk populations. So that's where we're headed. I hope that was helpful. I hope you got a good insight into how this project, not just how it was developed, but how we're trying to bring integrated primary care into the next generational step, where we integrate technology to do what we've been doing for a while, what organizations have been doing for a while, that is integrated care, but bring that into the next level using technology, some of these telehealth tools that we have access to. So my contact information is there on the screen, and we have a few minutes here for question and answers. So would love to open it up for questions at this time.
So as we talked about at the beginning, we have a Q&A function today, and somebody's already found it. We have our first question already.
All right. Well, I will go ahead and let me see what happens if I say answer live. Okay, so the question is, doesn't the ACO designation negate the rural location restriction for the ACO Medicare patient population? Answer is yes. For most ACO designations, that's part of it. And I think we're pretty sure going forward that's going to be across the board true. The challenge there, the challenge there is that we also have Medicare Advantage and other multiple populations too. So we can't. So at least that's a good thing for the Medicare slice of the population. That probably we can do telehealth for those and be okay. It's still a complex. There are complex payers involved. So yes, if you've got an ACO and you can rely on that rule within the ACO population, then Medicare becomes possible to be seen. Medicare population you can see by video. I hope that's clear. I think if you know enough to ask the question, you probably got the answer and know the answer already. So second one, what are some ways you're training your BHCs in providing telemental health? There are a couple of things that are key. The main one is practice, is getting them in front of a screen and getting them comfortable working in front of a screen. And so it's spending time in conversations. And I would say spending time in conversations that don't matter so much, right? Spending time in administrative meetings, in supervision, in just checking in and saying hi, so that you can get comfortable with the technology before you've got a patient sitting across from you. We had a bad situation arose. This is one of the most negative outcomes that I've seen, and it was a result of a number of mistakes. I could say they were made by others, and it's true, they were, but still, regardless of whose fault it was or whatever, I ended up with a clinician sitting across a screen, having a patient by video, first-time patient, first-time clinician by video, and the patient had a panic attack. And neither one of them knew what to do. There was no one else in the room on the patient's side. It was really quite literally a bad breach of protocol, in that the clinician didn't have the training they needed to know how to handle that. And even if they had been trained, they would have known that what they needed was a hotline number to call somebody to get into the room and help assist with that patient. And they didn't have that number. They ended up figuring it out, looking it up, talking the patient down, finding a number for the clinic, getting somebody to come into the room, and it resolved okay. But that's exactly the kind of a situation you want to avoid. So back to your question. Get people in front of the screen. Second, there are a number of training programs you can go through. Now, I've been a trainer for a while, so I work directly with my clinicians to understand what are the legal implications and ramifications, what are best practices for engaging patients, and there's a whole lot. Lighting and framing and audio and video and using your hands. You notice I use my hands a lot. I use it a lot more on the screen just because it's part of the whole communication medium. Because I'm not in the room with you, I have to make the most of the little screen that I have. And pacing and a number of things. Most of it boils down to the same clinical skills that you use in person. Maybe you dial it up a little bit, dial up the personality factor a little bit. Maybe you are a little more adept at managing technology and at helping people to get comfortable with the technology. But there are just, it's not a core, I wouldn't say that it's a core set of skills that a clinician needs, but it is a fringe set of skills that they add to their core repertoire, and that basically revolve around knowledge about and comfort with working over technology. Okay. Other questions or follow-ups? Anybody? All right, here's another one. When you see a Medicaid member from an FQHC via telemedicine, do you submit the claim as the hub? This is a good question. I'm glad you brought it up, because in Indiana, Indiana Medicaid has taken the position that a provider who is contracted or, in a sense, hired by the FQHC, who sees the patient, the FQHC patient, on site at the FQHC, is providing the exact same service as if the provider were on site at the FQHC. So in our work, well, technically Oaklawn doesn't have contracts like this. All of our FQHC contracts involve a provider who is on site. Our providers go out there and work for the FQHC. And the contract is with Oaklawn to provide that provider, but then that provider turns over billing to that FQHC, and the FQHC bills for the services. And that's a pretty common arrangement, that FQHCs can contract for a clinician. They can hire clinicians too, but they can also hire them under what's called a personal services contract or any other kind of arrangement. They have plenty of legal ways that they can hire and obtain services for people to come on site and provide services to their patients. So they do that, but Indiana Medicaid also recognizes that if the provider is hired in some sort of a legal way, any legal option to hire that clinician, and that clinician, of course, as part of the hiring process, turns over their billing rights. They don't bill as an independent person. The FQHC bills for their services. If all of that is arranged properly, then it doesn't matter to Medicaid whether the provider is on site at the FQHC or located somewhere else, wherever. They could be anywhere, but they're working by video within the FQHC. They're seeing the FQHC patient on site at the FQHC, and they are an FQHC provider. So the exact same situation obtains, and the FQHC can bill for that as an FQHC, which, by the way, is a better financial arrangement for that service than if Oaklawn were to bill it as a hub site. The hub site terminology almost doesn't work in that situation. It's unclear, and it doesn't even matter, because what we're really talking about is a contracting situation. And in Indiana, Medicaid calls it telecommuting. Which is a good model, a good term for it, telecommuting. I can do my job at a distance by telecommuting into work. The clinician is telecommuting into the FQHC to see patients and do their work as an employee or contractor of the FQHC. So hopefully that's clear. One thing that you do lose in that whole arrangement is there's no originating site facility fee. I think some people would make the argument, some people do make the argument, that there is still an originating site. It's the FQHC. They could bill the originating site fee and the professional fee. Actually, FQHCs wouldn't do that. They just bill their encounter rate. But other clinics that have this kind of contracting arrangement could technically bill the originating site fee, the $25 fee, and the professional fee at the same time. Indiana Medicaid specifically says, no, you can't do that for whatever, well, for obvious reasons. Other Medicaids haven't taken a strong stance. Medicare hasn't taken a strong stance. Medicare actually doesn't recognize the telecommuting arrangement at all. They just don't say anything about it. So we're kind of floating in a little bit of a gray area there, but that's just because the Medicare rules are still the same ones we've got from 1996, where these kinds of arrangements just weren't being done. Okay, hopefully I addressed that, and if not, if you still have some questions, you can follow up with us by email. Another question: would certification courses via my partners at the Telemental Health Institute help your team? If so, I can contact you. Yeah, Telemental Health Institute is one of the providers, one of the groups that provides training for clinicians to do telemental health work. There are also training institutes at the Global Partnership for Telehealth in Georgia, also at the Georgia Partnership, the subgroup that's in Georgia. There's a group out in California that does telemental health training as well, and several others that Becky knows about. So there are a number of programs around the country that can provide training in telemental health practices. And the programs vary somewhat. Some of them cover more technical issues. Some of them cover more legal issues. Some of them are more focused on specific state issues. Some of them just say, hey, make sure you look at your own state laws. So it's important to. It's still important to be very aware of where you're practicing and what rules apply. And the short answer to what rules do apply is that where the patient is located is where practice is happening. And so whatever rules apply to your practice at the site of the patient are the rules you have to abide by, regardless of where you as a clinician are located. So if I'm seeing a patient at an FQHC rules apply, but more to the point, if I'm in Tennessee and I'm seeing a patient in Indiana, Indiana rules apply. I have to be licensed in Indiana. I have to follow Indiana's rules. Choosing the telemedicine platform, second part of your question, what factors? We wanted something that was simple, something that we already knew how to operate, something that was inexpensive, and running Zoom video over those simple carts that I showed you just fit the bill. I had been working with Becky for years and other IRHA folks even before that, and folks out in California as well with telemedicine platforms for years and years. We've become kind of sold on the simple approach, and we really like what we can do with Zoom and what we can do running it as a program on a basic computer rather than within a structured telemedicine type of a unit or a telemedicine platform. So we're real happy with it, and just kind of chose it for its simplicity, and frankly, it's very inexpensive too, and that was a big deal for us. All right, one more question. How, if at all, is the Zoom platform integrated with EHR? It's not. We integrate that in our own heads. In other words, we're doing a video call We start and stop the video call. We are doing our EMR work on a laptop. So they're separate systems. Just like if we were on site, you know, I don't have a camera recording my session and telling me when I start and stop. So when I'm working over video, we use the same processes. I don't schedule it with a video platform. I just turn on and off the video when I need it. When I'm writing my chart note, I saw the patient starting at 1:32 p.m. and the session was 28 minutes long, and here's my note, and I submit it just as if I was sitting with the patient. So the video becomes a tool that I use, just like if I pick up the phone, just like if I, you know, walk into a room and use an exam room to see a patient. The video is just the room where we meet. It's not integrated, and I've seen integrated, non-integrated solutions, and it's slick when it can happen. We just didn't have the money or the time to work on some of the problems that integration brings. And the clinics themselves, they already had an EMR. We didn't have a choice to say, hey, your EMR is cool, but we'd like to use this one instead, or we'd like you to integrate something that we're doing. It wasn't an option. So we had to come up with a different way to enable our video encounters. All right. I think we're out of time. Becky, you wanna shut us down? Thank you all for your questions. I hope I've been able to answer them. If you have follow-ups, like I said, feel free to email me. My information's on the screen there. You can email Becky, and we can address your questions.
All right. Well,
let me stop the share here. All right.
All right, let me bring my video back on. So great questions. Thank you for your attendance today. Jonathan, thank you so much for coming in. I'm very eager to hear what happens in 3 months and what kind of things you have to say. We did record this session. We will broadcast this recording.